really, I don't know if you enjoyed it, but I just keep enjoying hearing these folks think about and talk about the work that they're doing to try to disseminate these evidence-based programs. There are a couple of things that I just note that I'm sure if I asked each of us, what did you get from this, people would have many different things. One of the things that I think is really interesting is to see how many of these different programs actually can fit in different organizational contexts and could be used in different organizational contexts. And that's both this wonderful, exciting promise, and it's also perhaps this danger, because where do they belong? Who is going to support these kinds of programs for families? Because we find them in the juvenile justice system, we find them in public health, we find them sometimes in education. We're going to hear from Tom DeShawn later on about putting family-focused programs in educational settings, et cetera. And so it's both a promise and also a risk that they fit everywhere in those, so therefore no place has real responsibility for them. Another thing that I think that I just continue to hear and that we all struggle with in our own work is this question about replication. Replication is absolutely essential. You know, we look at David Olds' work and say it's so important that he did 3 trials and learned from each of those trials more and more. And yet at the same time, we hear from every one of these people, my program is evolving, we're trying to do continuous improvement and make it better. And if you're on a group like the Blueprints Advisory Board, which I'm on, you'll find people who are saying, wait a second, that's not the same program anymore. It needs a whole new randomized controlled trial before we can say this is a promising or model program. This tension between replication and the need for replication, at the same time the need to continuously improve the programs to achieve better outcomes, is a big tension that we've got to struggle with in this area. I want to open this to questions and comments from the audience. I did think one thing that was really important was what we heard from Ron Prinz about the issue that Lauren raised initially. How do we create pull? How do we create demand for these programs and these kinds of interventions in families and in communities? And I think Triple P has been very exciting in its ability to try to get media strategies out into the public. In the UK, Matt Sanders did a kind of real-life TV, reality TV kind of series to get people thinking about these things. And if I were to ask a question of the other 3 presenters, it would really be, what have you been able to do? What have you been doing to create pull or demand for your programs from the final users, the end users of those programs? And I'm going to ask you those things in private maybe instead of in public, but I want to know about that from all of our programs, because I think this big question of how much are we pushing out there versus how much is there demand for evidence-based parenting and family-focused programs is a key issue. And I see Jose up there ready to ask a question, so I'm going to let him go.
Well, I'm Jose Shaposnik, and thank you all for an extraordinary set of presentations. I think it would be very interesting to hear the panelists talk with each other about what do you think are the commonalities in implementation across your programs. What works for all 4 of you?
I would point out one, there's probably several. There was a lot of mention about organizational capacity and climate and readiness and prep and pre-implementation things. I would say that probably fits with all 4 of our programs very easily. It takes different forms, but it's a meta issue.
Yeah, and I think Carolyn mentioned the importance of relationships. You know, it's how do you, one of the things that I didn't get to talk about is that, you know, when we looked at data on turnover, it matters who, you know, if system leaders turn over before the program gets off the ground, it doesn't happen. So, you know, how do you keep relationships going in the face of political changes and, you know, people just leaving their jobs who are key in, you know, getting things going. So I think, I don't know if that's it's certainly a tension for us, you know.
Just, I'll second that, or third it, or fourth it, whatever it is here. I think that we've done a study of participant retention and completed home visits in many sites in the U.S. using the NFP, and the single largest impact on participant retention was nurse retention. When a nurse leaves, the likelihood that the mother will drop out of the program is 7 to 8 times higher. Just
relationships at all levels. So the relationship between the nurse and the parent has to be good because you're modeling the relationship you want between the parent and the child. But the relationship between the clinician or nurse or, and the person who's supervising them or the organization, their administrators, their bosses, has to be really supportive and strong as well, and sometimes it isn't. And so I think that pervades all the levels of the intervention.
Other thoughts about that? Commonalities across these programs? We're hearing the importance of an organizational context that's supportive and that's able to be structured. And I know we'll be hearing from Invest in Kids in the next panel a little bit about trying to create a context in a community so that if the mayor does leave or the head of family services leaves or somebody leaves, that there is in fact a coalition there or a group of people who care enough about what we're doing that they can get through one leader or another. Brian Bumbarger will probably also be talking about that.
So David, I just want to pick up a little bit on that. I think that maybe we haven't said it because it's in some ways so obvious that staff need to be well prepared to deliver the program. And they need consultation in dealing with challenges that they experience. And if they don't feel efficacious in dealing with difficult situations, their commitment to the role is going to be undermined, and they are going to be more likely to leave. So that kind of ongoing both education, consultation, building staff members' efficacy, it seems to me, is really central.
And I think along with that, every one of you has been talking about an organizational that is kind of a backbone organization that's providing consultation, strategic consultation, coaching, sometimes certification of the people who are actually delivering these services. And I think that Lauren talked about this earlier, this whole question of what is we used to call it technical assistance system, now maybe we need to call it capacity building system that ensures that there is an ability for people who are on the ground trying to do it, whether they're trying to supervise it, whether they're trying to deliver the services, that they can get the support that they need to be able to do it successfully. Because, you know, so often what happens is somebody was trained to do it, and now somebody else just got hired to do it, and the person who was trained to do it before says, I'll take you out to coffee and kind of share what I know about how to do this, and you're on your own. So I think this is a big consideration and issue. Tom?
Carolyn,
You want to, if people could go to the mics. Oh, I'm sorry, I'm looking right, that's bad. I got to look both right and left. We'll get to you here.
Carolyn, you showed this map of the United States, and there were these sunspots around the country of sites that have implemented successfully, you felt were empirically self-sustaining and that the leaders were able to kind of forward the program successfully. I'm wondering, all of you have obviously had these success experiences, and I'm wondering what are the incentives for the organization to kind of reach that status for the leader, for the administrator? How do those folks achieve that? I mean, how does their career benefit from implementing an evidence-based program? Maybe all of you or some of you could speak to that issue. Because one of the problems I'm seeing is that folks who take on this enormous burden of implementing a program, how does it benefit their career? Or so I want to hear some success stories about that.
I don't know that there are built-in, sort of incentives for, but there, I mean, Larry Palinkas, who's at the mic here, when he did the interviewed system leaders in California about kind of who they relied on. I mean, I think a lot of it is you get a reputation as an innovator and kind of a mover and a shaker. I mean, does that benefit your career? I don't know. Maybe, you know, I often worried that if that happens, then they're going to leave that system and go to a bigger system, and you sort of shoot yourself in the, you know, in the foot in a certain way. But
I'd just like to say, I don't know whether anyone else is going to talk now, but I think in some ways, I think we need to be thinking about the long haul. And that it's really going to take us, I think, a long, long time to start to change the culture, the discourse in our society, where there will be an expectation that we collectively are going to invest in things that really work, and that people's administrators' accountability, hopefully, will increasingly be judged on the extent to which they're making good use of scarce public resources. So, is that happening today? No. Is there a movement toward creating that kind of culture? I think it is. I mean, I see that there is that change in discourse and set of values and so forth. Personally, I've just had to deal with this by taking a deep breath and saying it's really going to take a long time for us to get there, but there is movement. And I think that's what may lead to the kind of thing you're talking about, you're asking about, Tom.
Larry.
Larry Palenkas, University of Southern California. So, David, your comment about the long haul speaks to the question that I had for the panel. In your presentation, you talked about the fact that between the development of NFP and its scaling up, it was about 20 years, and Triple P, my calculation from the chart you presented, a little bit over 20 years. And every time I talk to practitioners and policymakers, one of the complaints I hear is, why does it take so long? And why do you want me to buy an intervention that was developed 20 years ago? Especially when circumstances that led to the development and the conditions that we were trying to address, you know, may not even exist today because of larger scale policy and social changes. So how do you reduce that gap or you know, come to terms with how many replications are enough, or the time frame in which you can conduct those replications, so that if they are context dependent, requiring adaptations, that at least we know the context that in which they were developed is the context in which we're trying to market it, or if it's a different context, you know, do we have a system of continual evaluation and continual modification?
Well, just, I don't know if it's different or the same from the others, but the Triple P actually started 35 years ago exclusively with home-delivered single-case studies. And it was not intended to be disseminated at that time, but that graph that I showed with the acceleration, even though it took a long time to develop all the pieces in the system, if you now look at the rate of studies and new variations and changes in the program, it's much faster. And so what was available in Triple P 5 years ago and is much different than what's available now, and the inventions within it that help practitioners deliver and help supervise and help support organizations on has accelerated. So it's not level, it's on the growth. But the other side of this is that we have to have a system that built into it can absorb change. It cannot be just, here's the rules, here's how you do the intervention, and that's it, and it'll functionally not change. Because that doesn't for example, going online. We didn't envision 20 years ago that programs will be delivered online, or maybe some of us did, but we didn't talk about it because we looked too futuristic. But now, if you're not developing online strategies, you're out of touch. And now if you can't do it on your smartphone, it's not good. It's not good enough to just do it on a computer. Well, all those things are happening, at least within PPP, and I suspect in some of the other programs too.
Uma Codical, I'm a pediatrician at Cincinnati Children's and drive the quality and transformation effort there. I'm interested in a question a little bit related to that around this tension between customization and standardization. It seems to me the opportunities for innovation that are customized around the individual are far superior to the opportunities around standardization of the deliverer. My second question is about the importance of co-production. So most of your programs are described as relatively doing it to somebody programs, even though you're engaging them. What is the importance of people designing the programs that make sense for them and you offering a network in which that can happen efficiently?
Maybe answer part of that. I think it depends on a couple of things. The way the programs can be developed in such a way that they allow for adaptation as part of the fidelity delivery. So for example, The Incredible Years is based on the collaborative model, which then means that the parents are identifying their goals and they're learning a set of principles that they can apply to achieve their own goals. I think that's why it works so much cross-culturally, because it's all different, right? So there are, sort of related to the earlier question too, there are a set of principles embedded within the program that haven't changed since 1979 when I did my first study. The way that the program has changed is not to change the core principles, but to add pieces. For example, if we needed a new vignette on how to deal with a parent in the grocery store because parents in a group wanted help with that. You know, they would tell us, as part of our evaluation, that those pieces they needed assistance with. I think back to a little bit about like developing the first car. The car is still the same car, but now it has seat belts and has airbags and it has power steering. It's been improved. But the fundamental aspects of the four wheels, the template, is still the same. So I think that what we're all doing is sort of adding pieces that we're learning from consumers, from the parents themselves, that needs to be there. But we're also learning how to deliver it in a collaborative way so they feel, I think when parents go through our programs, they feel they're doing it because they're making choices, they're setting their own goals to achieve what they want to achieve, which I think is why it works in Turkey and why it works in Africa and some of these different places. So that's sort of just one aspect to your question. I know it was a bigger question than that, but.
I just want to add one thing to what Carolyn just said, and that is that I think that, and someone else raises this issue as well, I think that there is an inherent tension between, if you want, the core model and these new augmentations, if you want, or innovations that get introduced. I mean, there are, for us at least, certain things that can be simply improved because they are already part of the core model that we've tested over the years. And we think for an example of that is observing and promoting parents' care of their children in the context of home visits. I mean, we used originally Catherine Barnard's NCAS procedure, some of you know about that, but we've learned that that was too cumbersome and hard for nurses to use, and it didn't align with the program model, so we developed a separate observation procedure and a streamlined clinical tool that would align observations with nurses' ways of interacting with families in their homes. And we didn't put that to a separate test in a randomized controlled trial. We just did it because it was clearly, the new method was clearly superior. But one of the things that we've also discovered is that the impact of the program on, say, child abuse and neglect is attenuated in households where there is moderate to high levels of intimate partner violence. And there really are no really good evidence-based interventions to address intimate partner violence. So we've developed one that is designed for the NFP nurses to use, and we are testing that in a cluster-based randomized controlled trial. So this tension between what needs to be tested, what can be simply improved, is something that I think we maybe collectively we could do this together to kind of sort out, well, what are some of the principles that would guide our thinking about how to do that well?
I'm afraid that our time for this panel is over, but fortunately, since you all have been sitting so nicely and quietly, we get a break. And there's an opportunity to talk among ourselves before we start the next panel at 11 o'clock. So we're going to start sharply at 11. Thank you.